I'm really grateful to the organizers for inviting me to this great conference. And obviously, many thanks to Dr. Musabi, Dr. Gulnara, and Dilnoza, and Professor Maria Buti and Lizaz. So I'll be presenting to you the hepatitis C elimination program in Pakistan. There might be quite a bit of overlap because Lubna has already informed you, but I'll try to skip those slides which are kind of overlapping with it. You have already seen this slide, and it says that we have the largest number of hepatitis C patients in the world. The prevalence might be not that high, it's 7.5%, but about 10 million people are suffering from viremia or have the active viral infection in them. And this is the data from CDA Homi Razavi. So this makes Pakistan as the country with the largest number of viremic patients in the world. And like with this kind of disease, we know that the disease sequelae is liver cirrhosis, decompensation, and then liver cancer. So it's kind of now predicted that Pakistan is currently also facing a liver cancer epidemic. And this is what we are seeing in our clinics, that previously we used to see maybe one patient or maybe two patients a month for hepatocellular carcinoma, but now there are almost 3 to 4 every day that we see. So we are also facing an epidemic of liver cancer in Pakistan. This is the prevalence. You have already seen this slide, and this is the prevalence in the different regions and provinces of Pakistan. And by and large, there are about 10 million people who are viremic. So this is again an analysis which was done by Homi, and this shows that if you don't do anything, we don't diagnose, we don't treat, then there would be increasing prevalence of hepatitis in the country, and then we'll have about 30,000 plus year of disability every year, and about 350,000 years of life lost every year. And this death and disability together will lead to a GDP loss of about $3 billion every year. So this is a huge loss that we can't afford. So, but if we start a very aggressive activity and treat and test people as recommended by WHO, so we will be able to really reduce the new infections and we'll be able to treat many. So the reductions in the hospitalizations due to the liver cancer and cirrhosis will also go down, and obviously the deaths will go down. So we will be in a win-win situation. So that's we then were able to convince the Prime Minister of Pakistan to kind of support us in eliminating this disease, because since we have a decentralized health system, so the provinces are the custodian of health. So federal government, by and large, does not have the role to play in the health of the provincial people. So, but when we saw that it was very difficult for the provinces to really support the population, because the population was large and the budgets were low, so we kind of pushed the Prime Minister to really take an action, and we were able to manage this. And the Prime Minister last year announced this program. And this program will be done all over Pakistan, and it would be in 2 phases, as told by Lubna. So we'll have about first year is 3 years, 2024 to 27, and then the next. And the sponsoring ministry is the National Health Services and Regulation and Coordination Ministry at the federal level. So this is the program overview, where we have taken a prevalence of 7.5% in general population. It's a locally funded, domestic funded program with a 68.25 billion Pakistani rupees. And this would be shared between the federal government and the provincial government at a ratio of 51 to 49. And as I told you, it's a 3 years program. So how do we do it? So the total population of Pakistan is 253 million. So it's a large populous country. So we are taking people who are more than 12 years of age. So that it makes about 165 million population who is eligible for screening. So because it's a two-phase program, so in the first phase, 50% of the population would be addressed, and in the second phase, another 50%. So what will the federal government do? It will it will support the screening of the whole of the 50% population, which is 82.5 million. It will support 30% of the PCRs, which is about 1.7 million, and it will support 50% of the treatments, that is 3.8 million, while rest would be provided by the provinces. So how did we choose this 50% of the population? So there are 4 provinces and the 2 regions. And then there's the Islamabad Capital Territory, which is the capital of Pakistan. So these are the 7 sites which will be, working on the 50% population. And we have chosen within the provinces, we have chosen the high hepatitis C infected districts. We kept on adding the districts till we reached about 82.5 million population. So that's the number of population in each province that would be screened in the first go. So before, although we have all kind of done this mathematics and we are about to launch the national program, but before the launch of the national program, there was a desire to do some pilot projects in some regions and provinces. And why was this desire? Because Gilgit-Baltistan comes under the federal government. And this region, unfortunately, has never treated hepatitis C, because anybody who was found positive for HCV was referred to the federal capital, and the federal capital would then test and treat them. So they had not done screening and testing and treatment at their own level. So we thought that because this is a program, national program, so now people cannot move to these long distances, so it's much better that we should train them and use them for enhancing this activity all over the region. So the Gilgit-Baltistan is a small region. It has a total population of 1.7 million, and more than 12 years is 1 million. So it's a small population which had to be tackled. So we selected 2 union councils which had a population of about 14,000 people, and all were screened using the WHO pre-qualified rapid test, and the data was entered electronically. Again, something very new for us, because most of the time people have been using the paper-based data, and this is the first time that we have actually started using the electronic medical record system. And then the venous blood was collected there and then, because they had, as I told you earlier, that these people were once found positive were referred to the federal capital. So here now they're doing the reflex testing. And even we have placed a PCR machine there, so they're doing their PCR also there. So the prevalence in these 2 union councils was surprisingly very low, but it might not be actually true for the other union councils, because we have got scattered, some sites have high prevalence and some have low. So this project we have already completed. And we have treated this population who was found positive. But in contrast, you see that Sindh, which is the second largest province in Pakistan, we used a district which is the largest district of Sindh. It's called Khairpur. And they have never used an electronic medical record. They were using a paper-based data, and they had never collected reflex blood. So in 2 union councils, 45,000 population was selected. And, like in Gilgit-Baltistan, it's very cold. It's kind of really, high altitude area. But in Sindh Khairpur, the daily temperatures were ranging between 45 and 48 degrees. It's scorching hot. So working in this, terrain was really very, very difficult. So we use a WHO pre-qualified rapid test, and about 48% of the population so far has been screened, which is about 20,000 people. And out of these, 2,400 have been found HCV positive. So here the prevalence is 11%. The PCR positivity is 50% because we, as Lubna also showed, so far we have treated about 20% of the general population of Pakistan. So some have been treated, some have had a natural seroconversion. So by and large, our PCR positivity, which used to be about 75% to start with, has now gone down to 50%. So this study is still going on, and we shall be finishing it in, I think, another 2 weeks. So what was the next step for us was that we thought that with after the launch of this Gilgit-Baltistan, we thought that it was easy to do and it was a small population. So we're going to eliminate the disease from this region in the next 3-4 months. And it's a joint venture between the federal government and the Khan Foundation and the network. We're going to support further 50%. So that's how the public-private partnership is going to work in this region. So that's the governance model of the national program that the Prime Minister has launched. So it has a national task force which is overseen by the Prime Minister plus the federal ministers and the chief ministers, and then there's a technical advisory group who advises the federal government. And then we have the program management unit within the Ministry of Health in the federal capital. And then you have the IT cell, a media cell, a procurement cell, a training cell, and the data analysis. And the provinces will be the implementing partners. So you have already seen that this is the EMR that we have developed, which works offline, online. And then we will be only using the WHO pre-qualified rapid tests and the PCRs. We'll be using the locally made medicines, which is sofosbuvir and daclatasphere. We have also generated the health maps of the facilities in Pakistan. So you can see there are about almost 32,000 health facilities which have been identified. This is the PCR capacity, and we have got adequate capacity to really cater for this population in all the regions and the provinces. So first, the position is that the first tranche has been released and pre-qualification of the vendors has been done. The procurement will start in the next few weeks. And the PMU office or the program management office, the posts for this have been advertised. And I think we should be in the field in the third quarter of 2025, starting the project on ground. So challenges, we have already, you have seen Lubna show these, that we have moved from paper to electronic data entry, and then we have engaged the private sector. We are doing the reflex blood testing, and we are using the, the PCR would be done there and there, and engaging the private sector. The PCR reporting would be done daily, and electronic reporting would be done to ease the linkage to care. And we have decentralized using the WHO's recommendation. We have decentralized the system, and we are using the task shifting. So decentralized means that from the federal capital or the provincial capital, now we have moved into the districts where the people the PCRs would be done. And then the task shifting is that our nurses or the paramedics would also be eligible to treat the patients, because there's no rocket science in giving a daclatasphere and a sofosbuvir. So, ladies and gentlemen, Pakistan has the highest hepatitis C infected population in the world, which is about 10 million. Apart from the private sector, we are also engaging the NGOs. And there are many challenges, but with all the efforts with the stakeholders, I think we will be able to, inshallah, eliminate hepatitis C from Pakistan in the next few years. So thank you very much.
Thank you very much. Next presentation from Philippines, and I invite our presenter, Professor Diana Payawal. Welcome.
Thank you very much for the kind invitation. And of course, I'd like to thank Gulnara. I know you're here. Thank you for this invitation, and I'm very happy to be here in your country. So I will gear a little different on what was in your program because hepatitis C is not really a problem in my country, but it's hepatitis B. But I'll give you some things that we are doing. So this is our national program on elimination for viral hepatitis. Okay. Last year, we published a work. So these are the issues that we are going to be giving out. We would like to understand the WHO eradication goals, review the epidemiology and burden, and present a strategic framework for hepatitis elimination. And at the end, come up with operational gaps and challenges in its implementation. Last year, we published a work on the Lancet on the different countries collaborating together on the so-called viral hepatitis elimination program and try to see what are the differences one country has over the other. So these are the identified 20 countries with most heavily burdened with viral hepatitis. Identified before you on red dots are those that are seen in Asia. Now, when you look at it closely, more than 5% of this prevalence, 5% prevalence in hepatitis B occurs in our region. So this is a challenge for us, and as I mentioned, this then produced now the demographics in Asia with the different countries with more than 5% prevalence. So I just highlighted the different countries: China, Indonesia, Myanmar, Vietnam, and at the end, the Philippines, my country. And you can see that hepatitis B vaccination is actually present in all the 5 countries. The hepatitis B receiving treatment is actually not a problem. Access to treatment becomes a problem to them. And of course, hepatitis C receiving treatment seems to be also a problem because of the cost of the drug itself. So even if WHO and all of these countries give us these drugs, it's the access and the most of these countries are out of pocket, and therefore being a very expensive drug has its own disadvantages. So here before you are the gaps that I identified. I think from the last 4 or 5 speakers, you've already gotten to know what the different gaps that actually cross around. Seems to be the same in all countries. So it is actually the insufficient awareness, as the COVID-19 produced a problem in some of the countries. And of course, there are already steps because this is a concern and therefore steps are being done to address the concern that has been given. And therefore, there are national action plan on all of the 5 countries. So what then is the problem? If all of them identifies the problem, if there is a national action plan that is already in place, maybe it's the implementation of these goals that comes to be the role of the government that becomes an issue of concern. Therefore, these are the identified hepatitis policy index. I'd like to highlight my country because it is from 2018 to 2023. So my country went backwards. If you can see, is this a marker? And you cannot use the marker in laser. So anyway, if you look at my country, it's backwards. Instead of the blue, which is 2018 going forward, which means you actually hit on your policy, my country was going back. And this then became a concern when I saw it. And it actually moved us to see where are we really now in viral hepatitis elimination? Are we going back because of the COVID? Or are we doing our share, but quite slowly? So these are the identified priorities. I think everything is there from ensuring diagnostics, access to treatment. You have to monitor progress. Financial is very important, especially in our region. Funding, and of course, the tests and models of care. And before you are the identified factors that are related to hepatitis B infection in Asia. Now, if you look the top one, it is limited availability of the epidemiological data. It seems to be across the board. And of course, the low level of awareness because there are more patients with hepatitis B in our region. Therefore, the healthcare workers burdened with all non-viral, non-communicable diseases then becomes an issue. And this is what a problem now. On top of the viral hepatitis that they have to think of, they have coronary diseases, they have gastroenterology, and colon cancer is also rising in our country, in the region. Therefore, this then adds burden as far as our healthcare workers are concerned. So this is what is happening in my country. The prevalence rate in 2017 is about 16.7%, and hepatitis C is 0.6%, but these are all in blood donors. The case fatality rate is about 0.82 to 1.29%. There is a high prevalence among men having sex with men in hepatitis C, and the prevalence data has gone down in 2017. And when you look at the burden of the disease as far as age group, you can see that we are doing our share as far as vaccination is concerned. Now, this is a surprise to us this year that when we did the modeling burden, we would see an 11% expected decrease by 2030, and for hepatitis C, an 84% reduction in HCV, and at 92 to 93% decrease in liver-related disease, morbidity, and mortality. So what then happens? And this is the new data, from a 19 or for 16.1%, we went down to 4.4% with 3.2 million adults living with chronic hepatitis B. And therefore, we did have a substantial decrease from a 1.7%, a 73.7% decrease from 5 years ago. So which means now that since vaccination program has taken its toll, it seems to be showing already its progress in our country. The highlights is progress in prevention and control efforts. And before you are the possible contributing factors. This is the improved vaccination, the enhanced blood safety measures, the better infection control practices, and the increased awareness and education. On the right side of your screen, this is what I was telling you. It was not really a problem as far as hepatitis C is concerned, but we do have, and this is about 0.2 to 0.3%. And it translates to approximately 220,000 adults with 100 million population base of the Philippines. Therefore, this is actually the first national representative estimate with a consistent with blood donor, which is about 0.3%, as I mentioned initially. And therefore, if you look at it, we are relatively low compared to the global estimate, which is about 0.7%. So I think hepatitis C will eventually be a thing that we can control, but hepatitis B is still something that we need to work on. With our last president who has very tough rules on drugs, because most of our patients with hepatitis C are on drugs, this actually helped us decrease the hepatitis C burden in my country. So what are the actions that were taken? Clearly, there are actually 4 actions that were taken towards viral elimination. We did have a national viral hepatitis task force, and this is actually to centralize the guidance policies and creation of different strategies for elimination. There is now a strategy of incorporating it to a primary care healthcare. Now, the reason is that we are not like the other countries. We are an archipelago. We have 7,100 islands that is actually separated by bodies of water. This alone makes me different or difficult to control healthcare. And we cannot be compared to the US or to maybe to your country because we need to travel. Patients need to travel to see specialists. And therefore, the need to educate your primary care physicians is a strategy that should be implemented in my country. We've expanded the access to screening and diagnosis, and this is using the community-based screening, as I mentioned. Even if your WHO gives us a screening, but they need to travel through the boat, which is what $100 or $200 just to see a specialist and just to get screened seems to be difficult for us to do it in the community. We need to enhance public awareness and, of course, improve immunization program or coverage. Now, this is the first thing that we did. This was before the COVID, and the COVID really helped decline this thing. This is the halt and reverse hepatitis B and C by 2030, our program of implementation and framework. So we are on the third process, which is at 2020 and 2022, which is the execution. And of course, the COVID did not help us at all. It actually shelved the hepatitis B. Our immunization programs were all at a problem. And this was seen in this figure. On top of your right screen, you can see that there are two problems that it went down. One is when there was no good information dissemination to our low-key community members. And the other one in 2020 is because of our COVID. But you can see the laws are in place, implementation is in place, but because of the different government problems that we have, this actually pushed that the coverage of immunization went down to 50%. These are the information dissemination, which is not different from what you all have. And we are doing our share both in private and public. And of course, as I mentioned, the different administrative orders are all there. It is actually the different strategies of advocacy, research, halting transmission, and access to effective treatment and monitoring evaluation. So these are the different operational indicators we have. That seems to be a difficult strategy, as I mentioned, because we are an archipelago, and I'm very happy that in 4 or 5 years, we have decreased 73% of our prevalence rate to what it is now. As I mentioned, financing is a problem, and therefore we need to have, we went down as far as using our maternal and newborn and healthcare strategy, working with our pediatric group. We have hepatitis screening. As you know, the Philippines has a lot of overseas workers, and therefore this is not being paid by our insurance system, and now we were able to lobby it. So this is one of the strategies we used because of the healthcare strategy. This is putting hubs. We call it hubs of hepatitis. We were doing this in 2020. We actually team it up with TB and HIV, but you can see that along the way it suffers because you need people to handle it. I remember we had to close down the hub because the TB, the healthcare workers became infected with TB. So that when people talk about this in forums that you need to put it with TB and HIV, it's so difficult to do it in the community level, in the real world scenario, because patients with hepatitis B will never want to see them coming in on an HIV clinic. So that seems to be a strategy that we need to move on. For hepatitis C, we have a memorandum already, and we were able to address this, as mentioned, a very low prevalence rate. So in other words, the gaps that were identified are before you in viral hepatitis, from the access to drugs to linkage of care, and of course, different strategies of putting it in government hospitals. And these are the different stopgap strategies that we did. We anticipated now, as I mentioned, primary care physicians to be moving on with us. The Hepatology Society of the Philippines is moving together with this. We have already to rethink our strategies for immunization, and now the Philippine College of Physicians is active in promoting not only hepatitis B vaccination, but adult vaccination. We are revisiting the different expansion programs in the DOH. And of course, as I mentioned, the Department of Health is getting into the limelight in the next few months. What happened? So the Philippine strategy is actually the same as the strategies that were identified initially. And this is a different one, not really different because maybe the only difference is we are an archipelago, and therefore we need to have hubs, we need to have people working together. And if you say you use a app, it's quite difficult because not everybody can be reached with a very good system of the internet. So these are the real world scenarios that we have to address, and I think we'll be there in the next few months. But I think the challenge here is the challenge to treat all. I've been pushing this for all of the conferences that we do because patients will not go back to me. So patients will need to be given a drug and maybe a treat all patients wherein you can actually decrease the amount of follow-up of your patients and probably the amount of testing, which actually will be now a problem because we need to see how this will actually have an impact. So lastly, I think we need to, you have a close parameters for your traveling and you do 10,000 steps a day. So we need to close the hepatitis circle together. You address on medical unmet needs, urgent solutions, research, and call to actions. Whether we are from a hero, zero to a hero. If you ask me, we are on track, slowly but surely. Thank you for your time.